All right. Well, thank you, everyone, for joining us here today for the webinar in the Clinical Discussions 2013 webinar series on improving medication safety. Just a few items of housekeeping before I turn it over to today's host. While we will be using the Mute All feature on the Genesis conferencing line, it is helpful if you individually mute your lines if you have a mute button. Please do not put your call on hold because we will hear your on-hold music. We will be offering a question and answer session following the last presentation here today, and we ask that you submit your questions using the chat feature of the WebEx. We'll also have other options available once we get to that section of the presentation. And finally, we will be offering a URL to download today's presentation. It will be sent out over email following the conclusion of the event. And without further ado, I'd like to turn it over to your host today, Dr. Adrienne Mims.
Good afternoon, everyone that's on the line. Thank you for joining us today. We're looking forward to a very exciting discussion about improving medication safety. This is work that we've been actively working on for some time, not just this current scope of work. And so we think that we have a lot of good information to share. We have today some success stories and then a discussion about barriers. When we get to the barriers section, we will have Anita Thomas from CMS offering some of her insights from our discussion today, too. All of the lines have been muted. You may use the chat box at any time to ask questions of the presenters, and we will field them as needed. I would like to say that we, as a group of clinicians working within the QIO, felt that it would be important to have a session like this because we know that we are working in the field. We are actually the boots on the ground across the nation who are helping these various clinical teams to improve the safety of their Medicare beneficiaries and others who will be also affected by the care and services that we provide. I would ask that you be open in sharing and engage vigorously in our dialogue portion when we get to that area. I would like also for you to keep in mind that we will not be spending a lot of time on the call dwelling on issues regarding the contract itself or the deliverables. Those are questions that you should pose to the GTL or NCC. We have raised those previously up to the higher ranks of CMS, and they understand for this particular aim that there's some areas that could be improved upon that we will find out about next month. We have been given the opportunity to write a narrative about our work. Keeping that in mind, I'd like for that not to be the focus of our discussion today, but rather to be collaborative and in sharing your best practices. I would now like to turn our discussion today over to our facilitator for today. Excuse me, I'm sorry, we had some polling questions. I really wanted to know who was on the line today. Are we able to pull up these polling questions above the chat box? I wanted to know who was on the line and participating with us. These sessions are intended to be available and utilized by a wide reach of people. So you see your first polling question has been put out. Please go ahead and answer this based on the type of work that you do currently within the QIO. We will have a second question that comes up after this one, but I first want to get an idea of who actually was on the telephone today. So the poll is now closed, and I would like to see the results, and you'll be able to see those also on the right-hand corner of who is on the line today. Once that shows up, we will also be looking at the second polling question that was listed. So we can see here that most of the people on the line are working in quality improvement, and you were directly solicited to be on today. We have a wealth of people. We have people in analytics, and we also have physicians on the line. The second polling question, if you can bring that up, is how involved are you right now as you're working in this contract, specifically with adverse drug events? We know that we have invited a variety of people to be with us today, and I just want to get a feel of how involved people are as we get started on the subject. This is also helpful for the presenters to get an idea of who's actually on the line. And as the polling will be going forward and closing, I'd like to turn it over to our facilitator for today, Darren Triller. Darren is a very involved person within our QIO network for medication safety. He's in the New York area, and he is a pharmacist, and so he's quite well versed on what the patients need to know and how the systems can evolve to make them safer. So we see here that the poll has come up that we have a variety of people involved on the line today, and thank you for answering the poll. Darren, I will now turn it over to you. Darren, you'll need to unmute your line at *6*. Darren, are you on the line? Okay. Darren, it's *6* to unmute your line. Well, let's go to the first set of slides here. And what we're going to do today with our agenda is that we will be having success stories. And the success story that we will start with, we have several of them who are on the line with us today. After we finish a series of success stories, we will then go into a discussion of barriers or gaps in trying to improve the work of medication safety. We will open then up to question and answers before we adjourn. So please feel free to write your questions down in the chat line that we have. And I'd like to let you know of our learning objectives for today. Number one, we want to describe successful community-based solutions for improving medication safety. We want to identify what are the barriers that we are currently facing in the field and share best practices of how we can overcome those barriers. And the third thing is that we want to reveal the opportunities that others have found to overcome those barriers. Darren, are you with us now?
I believe I am, and thank you. I was unmuted earlier before we went live and then somehow was muted, but I said all sorts of wonderful things that no one could hear. So thank you for the opportunity. I was saying to myself out loud, I guess, that I want to thank the Pharmacy Leadership Network for the opportunity to speak, that many of us, pharmacists and others working on the ADE tasks across the country, are very excited about the work on drug safety, and the opportunity to speak to the Physicians Leadership Network and the CMS is very helpful because this is a multidisciplinary issue, and we really do need to have these opportunities. I also wanted to say that the stories from the different states that I've interacted with over these past 7 years working on ADE tasks are all varied, so you'll hear very different stories from different QIOs and different partners within those states. So even though the stories are varied, I think I could speak for everyone that the excitement about doing the ADE work is the same, regardless of where you go. That everyone is very excited about this line of work. I know I can speak for our own team of 3 here at iPro on ADE that all 3 of us within the last several years have had a family member affected by an adverse drug event relating to warfarin. So it does strike home. So we are all very excited about doing the work. As Dr. Mims mentioned earlier, we are going to touch on success stories, but also on some barriers. And I think the context of the discussion on the barriers is important, that we're also bringing forth suggestions for improvement in each of those areas. So it's not so much barriers that can't be surmounted. They're obstacles that I think we all believe that if we work on them effectively and get around some of these barriers going forward, we could actually do much more work, have much more value for our own families, for the beneficiaries and things. So the faculty for today, I'll introduce them individually for the success stories, but I will just touch briefly on the barriers and gaps. Instead of having 6 or 7 different people speak over the course of 20 or 30 minutes on the barriers, we thought that it'd make more sense to aggregate information from across a variety of states. So what we did is we had certain names that you see listed here, people suggested to us from the other QIOs. We developed a Excel-based tool that we circulated and aggregated identified barriers from certain domains of the work that we're doing. So whether it was in recruitment or sustainability, with specific measures, with data, with reporting, we thought by doing that we could collapse the presentation into a cohesive unit that would make more sense so we can walk through these areas. And again, we'll have opportunity at the tail end to do questions and answers. So Rachel Digman will be presenting on behalf of this group, but please note that there was input from a variety of states, and we do appreciate everyone who contributed to that. So with the next slide, if we could, please. We're going to start with success stories. Do we have Lori Thomas on the line?
Yes, I'm on the line.
We do have Lori. So I'm going to turn it over to Lori Thomas. Lori's going to share with you, I think, one of the early steps, which is very important to any of the work that we're doing, regardless of the project, which is recruitment. And their state in Indiana, they did a remarkable job in which can be the most challenging part of the work, which is getting teams to work with you. So with that, I'm going to turn it over to Lori.
Hello, everyone. And as was said, I am going to talk to you today about the recruitment strategy that we took here in Indiana. When we started on this project, I was actually new to the QIO, and so one of the first things that I needed to do was, first of all, learn what a QIO was, and then also learn what other initiatives were going on with this contract. So I felt very comfortable in working with our care integration and nursing home teams. Everyone was very helpful, and very early on it was easy to see that there was such a great correlation between the work being done in the drug safety initiative as well as care integration and nursing homes. So those project leads here at our QIO were very helpful. And we were looking for potential synergy between the initiatives, and we felt that it was very important to evaluate potential opportunities that existed with partnerships that we'd had for a long time, and we felt that that was really a key to success moving forward. One of the other things that we did early on was to look at the PSPC 3.0 materials, which I'm sure most of us did at that time. That's what was available. But what we found helpful was that there was a list of the existing PSPC faculty, one of which was Rebecca Cheek, who was located in Kentucky. So we met with Rebecca, and she was extremely helpful to us. She had been participating in the PSPC since its inception, and so we felt it was very important to understand what got her involved in the first place, what motivated her as a pharmacist to get involved, and we kind of used that to help us design our strategy when we were meeting with potential partners. And then after having all this correlated, we developed a plan of action. So next slide, please. So our first strategy was that we felt one of the challenges that faced us was the number of beneficiaries that were going to be required per team, which at that time was 100 Medicare beneficiaries. And that did seem a bit overwhelming, and so we were looking to see where can we locate the number of patients that would be required and also have an opportunity to make an impact and really see some improvement. And we really felt there was a really good correlation to long-term care. We saw such a high prevalence of polypharmacy in that arena, as well as the link with readmissions due to medication errors and emergency room visits. So we reached out to a long-term care pharmacy in Indiana, and we met with their senior leadership. We met with the Director of Clinical Pharmacy Services as well as the CEO, and it was actually a very easy conversation. we found that we did have aligned goals, and so we talked about those. We really felt that it was very important for us as a QIO to show what value we could add to some of the goals that they had as a company. And so we really developed a strategy that incorporated that and tried to find ways that we could help support that moving forward. So we looked at the long-term care facilities that were supported by this Grandview Pharmacy, which was our partner, and we decided that while we had a list of many pharmacies, it did narrow it down to probably 10 to 12 that they thought would be a good fit, and we decided to start small with one team, which was a high performer. And we felt that it would be helpful to make sure that we had a good process in place for collecting and managing that data. What tool were they going to use to capture the data? How could they get that data then reported up to the QIO and into the outcome site? So we spent some time really working with that one small team while we built on what was learned to use spreads down the road. So as you can see on the next slide, in PSPC 4.0, we actually had only one team. But now, in moving into PSPC 5.0 in Indiana, we have 21 teams. We have greater than 700 beneficiaries that are enrolled, and 19 of our 21 teams are currently reporting data. The other two teams are still working through a few struggles, but we'll have them up and running here pretty soon. In the next slide. Some things to keep in mind. From the pharmacist perspective, their goals were really to demonstrate the value of the consultant pharmacist. They were very passionate about improving patient care, and they wanted to create and implement diagnosis-specific monitoring plans for medication therapy management in the facilities that they were working on. So this was independent of what was being asked of them in the PSPC. They were collecting the data that we were requiring of them in that first team, and concurrently they were developing more robust monitoring plans with the help of all the consultants that work for Grandview. They started with diabetes, and while they do collect our measures, there are probably 16 to 18 additional measures that they're collecting on each patient that is a diabetic, and actually all of the facilities for which they provide the pharmacy services. So while they only had the one team enrolled, as they got this diabetes tool up and running, they did implement that first slowly, working with 1 to 2 facilities that each of the consultants worked with, and they did PDSA cycles to improve that tool. And then after they had that fully refined and working, they then rolled that across the board to all the facilities that they support. And then as diabetes became successful and that was built into their normal workflow, they then moved on and added the antipsychotic data collection tool, and they have just recently implemented another tool for heart failure. In adding the additional 21 teams, they did start adding the ADE and PAD collection for the PSPC teams only, and they've actually just started slowly rolling that out, and we should have all teams reporting the PAD and ADE information here in the next month. Next slide, please. So how did we as a QIO support this success and look for ways that we could sustain it moving forward? One way is that we felt it was important to have statewide specific learning and action network events. And the first one was held back in November of 2011, and at that time we actually brought Rebecca Cheek, who had been a PSPC faculty member to Indiana, as well as to our Kentucky Learning and Action Network events, and she presented to everyone about what the PSPC was and what value she had seen in her clinic in the work that she had done. And we've been assisting with data reporting. So as I said, the teams are collecting the data, the pharmacists are collecting the data. So our projects are all pharmacy-led. And then I am actually working with them and entering their data into the outcome sharing site and uploading that. So that is our process. And then we felt it was important to capture and share the success stories. And really what I think we've seen as one of the most successful outcomes is the increase in recruitment, because it has really, the success stories that we have out there has really generated interest. 16 of the teams that we have that are active are from one nursing home corporation, and it's Hickory Creek Foundation, and they pledged to participate 100% in this initiative, which was a huge success. And as that story has been shared out, we've actually had additional interest of corporations reaching out to us. So the potential is very great here in Indiana, and we're very excited to see how this can spread as we move forward. Next slide. And that's it. Thank you.
Thank you very much, Lori. And I remind everyone listening in that you can submit questions, and we'll get to them at the tail end, please. And everyone can hear me all right, correct?
Yes.
All right, wonderful. So I'd like to go on to the next slide and briefly introduce Jennifer Thomas. Jen has also been working on the ADE work for quite a while, and has been very successful in her projects down in the Maryland area. So without further ado, I'm going to pass it off to Jen, who's going to discuss some more lessons learned related to collaboration.
Good afternoon, everyone. Thank you, Darren. Next slide, please. And the next slide. I will relate a success story through collaboration. Collaboration works. This is across two aims in the current contract, of course, the patient safety and the adverse drug event reduction project, and also with our care transitions group. And the focus is around an independent retail pharmacy who are a Maryland PSPC team. They have a diabetes center. They provide NTM services. And other partners and stakeholders with interest are the large regional health systems, information technology vendor, the Maryland Health Information Exchange, and, of course, our Care Transitions Coalition, the Eastern Shore Coalition here in Maryland. And that includes the listed stakeholders and some others. I want to mention the University of Maryland Eastern Shore School of Pharmacy, and obviously Department of Aging, Nursing Home Assisted Living. There's also hospice, home health, the QIO, of course, and, of course, our PSPC team. Next slide, please. This project really began with needs that were identified. This was a request from the PSPC team to the Eastern Shore Coalition and the QIO, and it simply was their lack of available access to patient health information to help them with the care of their patients. So they simply asked during a coalition meeting, was there the possibility that a pharmacist could connect within the regional medical centers and or other options to obtain health information to help manage their patients? And one of the regional health centers there, Peninsula Regional Medical Center, expressed an interest in partnering, and this particular center provides approximately 50% of the hospital care in that area. So myself, the QIO, organized and facilitated some discussion calls with interested parties, including the health center, the team, the School of Pharmacy, and eventually the information technology vendor. These calls were teleconferences monthly for the first 4 months, and then we met in the site of the PSPC team's pharmacy and included the information technology vendor to continue discussions. Next slide, please. So that was really the first option, was some discussion between the health center and how that might, connectivity might be established between just the pharmacy and the health center. And that discussion is continuing underway. And actually the discussion, there's interest on both sides for having bi-directional feeds because the hospital is actually interested in the pharmacy profile data as well. And the pharmacy is interested in diagnostic, laboratory diagnoses, and perhaps vital signs from transfers. The second option that we discussed and have moved forward with was the actual connection of this pharmacy with the Maryland Health Information Exchange, known as CRIS, and that's Chesapeake Regional Information System for our patients. And that dialogue began with my opening a conversation or calling the exchange and requesting access for pharmacists. Was that possible? And then in collaboration with a program here called P3, which is similar to the Asheville project, we had continuing conversations. Chris was interested to know why pharmacists needed the information, but we were able to indicate in our telephone conversations and with some information that pharmacists were currently managing patient care in diabetes, hypertension, and hyperlipidemia here in the state, and this was a good thing. The pharmacist was granted access. They registered. They completed the training and have been able to have an access. And there is some limited data now available in the CRIS to this pharmacist, and they are the first pharmacy in the state that I'm aware of that has actually connected to CRIS. And then a third option was with the IT vendor, this is Relay Health, and their association with the particular medical center. They have a personal health record that the center would definitely like their patients to avail themselves of, and it's called My Pen Care. And patients can allow providers, including pharmacists, physicians, pharmacists, and others, to have access to their records, again, when the patient allows that. So this particular team, if we go to the next slide, has registered and has obtained an account for My Pen Care, and has had available data, has achieved approval from some patients and some practitioners in the area to allow them to have access to this data. And you can see here that obviously medication lists and laboratory test values are something that's important for obviously the patients and their providers to see. Next slide, please. And I think this quote, I wish I had said it myself, but it really makes the case here. And so in working with this particular medical center, with the Chief Medical Information Officer and the Director of Pharmacy, and this is his quote, basically indicating that there really is a necessity to the community pharmacists to have access to this data and enhances continuity of care, and the lack of it there places the pharmacist in a reactive role rather than a proactive role to help patients with their medication concerns. And the data for the current project is listed here for you on the right side, and you can see there's been a dramatic decrease in those patients that have an A1C greater than 9 from over 43% to 8%, and significant reductions in both the ADEs and PADEs. So in the next slide, you'll see a photo, a group of the team, the owner there of the pharmacy. This is a small, actually independent chain of 3 to 5 stores, and there are 2 certified diabetes educators on either side. And this has been a great team to work with, a success story, and I think a model that others could follow. And I want to thank you all for your attention.
Great, thank you. And can you hear me again? I'm off mute.
Yes.
All right. Thank you, Jennifer. That was fantastic. I know we're jotting down notes here. Honestly, the idea of community pharmacies accessing lab data is, we think, key to any real high-quality pharmacy services, and we've been unable to realize that up here in our area through our exchanges. That's very exciting stuff. So I did receive one question, but we'll hold it till later. So if we can go to the next slide, and Jennifer will loop back with you with a question at the tail end. Gina Partington is now going to speak to us on a very hot topic. She's going to talk about keeping the fire burning and maintaining teams' engagement as you work with competing priorities through the scope of work.
Thank you. And thank you for inviting me to share the Carolina Center for Medical Excellence, or CCME's, success story related to work in the Adverse Drug Event Project and maintaining engagement with our team. I'm very fortunate because I work with a great team here in North Carolina that is very enthusiastic about this work. Our 11 North Carolina teams are also doing really great work because of their dedication to providing quality care and improving outcomes for their patients and residents. This makes it quite rewarding to be the team lead for this project in North Carolina. First, a little history that will set up my presentation for maintaining engagement. In the beginning of the contract for the 10th scope of work, our scan for any teams already working in PSPC, or the Patient Safety Clinical Pharmacy Collaborative, revealed 3 teams in North Carolina. We quickly realized that in order to encourage these teams to partner with the North Carolina QIO, we had to add value to the teams because they were already doing this work on their own. We started this conversation by asking teams what quality improvement work they were already doing that we could support, or what quality improvement work did they want to do that we could help provide resources and technical assistance in order for them to move forward. We've used this model with all our recruited teams, and it has worked well thus far. So on this slide, I will talk about how we're maintaining engagement. And so we were able to recruit 11 teams, but keeping them engaged for 1, 2, or 3 years, depending on when they were recruited, is another aspect of the work that we need to make sure we are continuously addressing. So how do we do this? First, with collaboration with the teams. And the North Carolina QIO is an active team member, but not the team lead. So we're not there to be prescriptive, but to help guide the work, help focus the work, offer suggestions, and pitch in with the work as any other team member would do. As far as individualized needs, because part of the QIO work is to provide technical assistance, we let the teams know that the help we can provide is based on their unique needs. What we provide to one team is often very different from what we provide to another team. But so far, this assistance has included process mapping, root cause analysis, providing content matter experts, tools and resources, and scanning the environment for educational opportunities such as webinars and in-person learning sessions that are applicable to the work of the team. As far as in-person meetings, I can't really diminish the value that meeting face-to-face on a regular basis with each team has toward maintaining engagement. Prior to each meeting, we provide an agenda, which includes reviewing action items from the previous meeting, discussing the status of their PDSA cycles and interventions, reviewing the data for improvement or barriers, information about upcoming educational opportunities, and any needs of the team that might arise from these discussions. Following each meeting, we send out minutes that include the content of our discussion, any action items, and the date and time of the next meeting, which is scheduled prior to the end of the current meeting. Celebrating successes is also very, very important to maintaining engagement. And the teams are doing great work, but they're so busy actually doing the work that they rarely, if ever, stop to reflect on the great job they're doing, much less submit notice to others that will highlight their successes. And this is one of the favorite things we do for our teams to make sure that they're recognized. We've been very fortunate to have several of our team successes published in the PSTC weekly newsletter, in CCME's provider online newsletter called Quality Partners. Some teams have been conferred awards at the National In-Person PSTC Learning Session, and publication of their work in the PSTC Change Package for putting action into action items also has been a mechanism for spotlighting their work. Next slide, please. So, in summary, we believe these activities to maintain engagement are helping us establish strong relationships with our teams and the organizations they are part of. Our support has certainly shown the teams what they're capable of and what they can accomplish above and beyond what they're already doing through partnering with the QIO. Hopefully, these relationships and accomplishments will take us and these teams into the 11th scope of work for further successes. So thank you again for allowing me to tell North Carolina's story in this important work related to medication safety and improving outcomes in high-risk populations.
All right. Thank you very much, Gina. Again, if you'd like to submit questions online for Gina, we can circle back to them at the tail end. So you can hear me all right, please? All right. Okay, going on. We do the next slide. We'd like to introduce Jim Turpin from Texas. Jim has also been waist deep in the ADE work for a number of years at the QIO and is going to speak briefly on the utilization of rigorous data processes and engaging the teams and driving improvement. So, Jim, are you with us?
Yes. Good morning, Darren.
All right. It's all yours.
Let's go to the next slide, please. Again, I want to thank Darren, Dr. Triller, and Dr. Mims and the folks at AQUA and IITC and TC for allowing TMS Health Quality Institute at the Texas QIO to present today. I'm going to be briefly talking about stakeholder engagement and through stakeholder engagement how we have the maximum Medicare beneficiary impact. Next slide, Jim. Many of you are aware who've been around a while that the drug safety aim has been in the CMS QIO contract since the 8th scope of work. Just a really brief history on that. In the 8th scope of work with the beginning of the Part D benefit for Medicare beneficiaries, the QIOs were allowed to develop their own drug safety project. TMS developed a drug adherence and persistence measure for lipid-lowering agents antipsychotics, and in the ninth scope, many of you are aware, there was a potentially inappropriate medication and drug-drug interaction measure. TMF worked on propoxyphene, that's the PIM, and warfarin amiodarone for the DDI. And then obviously with the 10th scope of work, we're working with HRSA, PSTC project, and the 4.0 and 5.0 project. Through those many iterations of drug safety projects over the last several contracts, we developed a number of really good relationships around the state. Many of them are listed here. We've worked with Medicare Advantage HMOs. We're now working with some new providers, federally qualified health clinics. We work with county hospital districts for a number of contracts. And then we work with for-profit clinics for a number of years. Texas has the good luck of having fairly significant Medicare Advantage HMO penetration in our state. So I know other states don't have that luxury, but that's been quite helpful in this particular contract. And one of the ways we've helped engage stakeholders and really sell the value of this particular project is by really looking at accreditation guidelines that they really strive for, the MAHMOs. That being Joint Commission and/or NCQA HEDIS accreditation. And what we've done is we've looked at how the PSPC project and the goals in the CMS contract have trued up with NCQA and Joint Commission, and that's been a really good sell for us. So when we've gone out and recruited these providers, that's been quite helpful for us. At present, TMF Health Quality Institute has 5 ADE teams with those 4 different types of providers that you see above. We have FQHCs in our project, we have Medicare Advantage HMOs, we have county hospital districts, and we have for-profit clinics. And of those 5 teams, we presently have over 700 Medicare beneficiaries. By the end of the contract, we'll have 7 teams will have recruited. We're presently working with 2 more FQHCs right now to get them in this project, and I feel really confident we'll have them on board quite soon. Next slide, please. Now, one of the ways we engage stakeholders is really through the use of adverse drug event data. Now, one of the caveats we have is when we recruited these providers, we only work with those particular providers that have health information technology, or HIT. By that I mean EHR, electronic health records, CTOE, and/or e-prescribing. Why is that? Well, the reason being is TMF cannot go out and do chart abstraction on over 700 Medicare patients, every month. And also, to be quite honest, we don't want those providers doing that chart abstraction. That's time taken away from them providing good clinical pharmacy services to those patients. So, again, we want them, those partners we work with must be HIT enabled. Now, because they're HIT enabled, we want to help them with their data. So through a signed data use agreement and business associate agreement every month, they send us their ADE data through QNet or QualityNet, which is the encrypted CMS FTC portal, or through on an encrypted disk to us monthly. That data obviously includes those types of data points we find valuable: outpatient encounters, CPT, ICD-9, HCPCS, along with their prescription drug data. We then take that data monthly, do analysis for them, and produce this is I think, kind of the apple on the tree for them, organizational summary reports and individual physician summary reports, and also in most cases, if a lot of these physicians we're working with are in clinics, we also produce clinic level reports for these team members. So again, what's on that information? Their ADE count, their TAD count, INR, A1C rates, and it includes trending graphs so they can see where they're going. Now, many of our teams are submitting their own data to the Healthcare Communities Outcome Sharing Pack monthly, but I'll be really honest, a lot of them are still having trouble, as I've heard some other QOs say, and we assist them with that upload every month. So, again, you're not going to be able to do quality improvement unless you have the data in your hand. So that's a really good engagement tool for these providers. Next slide, please, Jen. Why are these reports useful? Well, I like to say in presentations that data is everything, but if you're not using those reports, if you're just getting the reports, they're of little value. So, why is this useful for these particular teams? Well, honestly, it keeps them accountable. As we show them these quarterly reports based on the monthly data we get from them, It's quite important that they see where they are, where they're going. Also, it's opportunities to identify areas of improvement based on the parameters I discussed earlier and based on the population of focus. All of our teams are either working on the diabetes measures or the anti-coag measures. Also, it's opportunities for us to basically take that data and marry it up to technical assistance. Now, they're very excited to get our TMF ADE toolkit, and again, we only give them evidence-based tools, whether it's tools we've developed or from AHRQ, Agency for Healthcare Research and Quality, or the American College of Chest Physicians, or ADA, etc. We make sure that the tools we give them are evidence-based. And honestly, it's an opportunity to also identify recurrent patient and physician outliers. We do root cause analysis quite frequently. We had one of our teams recently that had, we showed them as a hospital admission for a patient that was in for almost for 21 days, and many of these, including the Medicare Advantage HMOs, are trying to reduce, obviously, admissions and readmissions. Next slide, please. This is a quick screenshot, and I apologize, it's a little small, but this is one of the individual physician reports for oral hypoglycemic agents. It's a 2-page report. This is the one they get quarterly. The slide on the left is really a bar graph that looks at their ADE count, their TAD count, and their A1Cs greater than 9%. The slide to the right is really the individual patients that it affects. And again, if they can't figure out what patients it's affecting, these reports have no value. So for us, we developed our ADE count based on diagnoses, obviously hypoglycemia, those types of diagnoses for ADE. And for PADE, we developed that count based off therapeutic duplication and drug-drug interaction. We had the University of Texas at Austin College of Pharmacy and the UT Health Science Center San Antonio School of Medicine help us develop these ADE and PADE parameters. So again, we try to bring in these academic partners to help us with that. With that, it looks like I may be going over time a little bit, and I'll turn the presentation back to you, Darren.
All right, great. Thank you very much, Jim. So we've got, I think, according to our agenda, about 15 minutes before we're supposed to get over to the questions and answers. I definitely want to leave time for Anita to chime in based on what she's seen. So with the next slide, I'd like to introduce Rachel Sigmund, who has graciously offered to present the aggregate information that we put together relating to barriers. And so with that, I will turn it over to Rachel. Rachel, are you there with us? Go.
Okay. Well, thanks, Darren. If you want to go ahead and take a look at the slide on your screen, this is just a list of the people who participated in our work group who was looking at barriers. I want to once again thank everybody for their participation. Next slide, please. So moving straight into the meat of the issue, we wanted to address the fact that we currently understand that ADE work is incredibly important. ADEs contribute to a significant amount of Medicare admissions. The 2006 ILM report had 1.5 million preventable ADEs annually, and they estimated that each cost about $8,000 per event. So this is a significant area that we know we need to work on. So we're happy that it's part of the scope of work, and we hope that it continues. The ADE, PADE is a common theme amongst all different care settings, and we know that 50% of medication histories taken at admission have some form of discrepancy, and we also know that 50% of the documented med errors occur at 3 different times. These are admission, transfer, and discharge. So we know there's significant opportunity for improvement. Next slide, please. So as Darren described at the beginning of the presentation, we created a rubric that we use to capture information from all those on the work group. It's to provide a snapshot of the different barriers across the different settings. We wanted to avoid redundancy and have a comprehensive look at the various different issues that we were seeing across the nation. Next slide, please. So as I mentioned, this was a rubric, basically an Excel spreadsheet that we worked into several different domains, which I'll be addressing in the upcoming slides. Each barrier we've accompanied with a suggestion or a recommendation. Next slide, please. So the first thing that we wanted to address was the recruitment. Based on state size, geographic size, population, or their urban versus rural setting, This posed unique recruitment issues for each individual QIO. There's also variability between different sites. So FQHC clinic settings had an ability to collect adverse drug event and potential adverse drug event information that's different than someone in the long-term care setting or a community setting. As I believe Jennifer mentioned earlier, community pharmacies may not have access to lab data, but they may have a lot of information on Medicare beneficiaries and adverse drug events or potential adverse drug events that may happen. The same for hospitals. They don't have a set or captured population of patients. They're turning patients, in and out. So how do we capture that information, and did this current structure allow us to do that? So some suggestions that were brought up from the team were to allow recruitment based on state characteristics and identified need of the state, to allow recruitment of teams based on the site needs and considerations for other quality initiatives that are going on site-specific. So long-term care, community pharmacy, hospital settings, what other quality initiatives are going on in those settings. And we also would like to see that there would be a modification of intervention models that would allow for flexibility within settings as opposed to one set structure that may have been modeled for one particular setting, such as an FQHC, as opposed to allowing other interventions in other settings. Next slide, please. Other suggestions on recruitment, as I think Jim mentioned previously, providers have several different competing priorities in all the settings that we're talking about. In some areas, in some QIOs, they were able to align those priorities with those recruited teams and or even take over some of the data collection requirements. But this isn't true for all states, and that has created a bit of an issue with people recruiting and staying engaged in reporting because of their needs and other competing factors. So we are suggesting that we align the ADE work with other high-profile initiatives, quality initiatives such as QAPI or BBP, OQR, meaningful use, those sorts of things that are currently going on and will likely continue to go on. We also are recommending data submission requirements need to align with the necessary timetables. So, quarterly submission versus monthly submission or annual submission, we need to make sure that those are specifically aligned and refrain from putting additional requirements on teams that aren't necessary. Next slide, please. The next domain was on data acquisition and suggestions on those data sets. So currently there was no uniform documentation practice from various sites. So as Jim mentioned, some clinic settings had EHR, some didn't. Community pharmacies may or may not have the ability to collect information, same for long-term care facilities. Also, we have teams that are doing coded claims for ADE versus self-reporting of adverse drug events and potential adverse drug events. So this lack of uniformity kind of dilutes the results that we're getting, and so that has been an issue across the scope of work. There's also various interpretations on the definition of an adverse drug event, potential adverse drug event, and this lack of an operational definition has also created some confusion and dilution in, I think, the results that we're getting. So some of the suggestions were to, moving forward, provide a standard operational definition for the parameters and the data that we want collected. Where applicable, we again encourage the use of validated measures that align with other incentives, such as NQS or other BBP measures that have already been set. We would recommend the use of discrete data elements when possible, and we want to facilitate QIO acquisition of needed data files, such as Part D claims, since there seems to be a lag in the ability to access that data. Next slide, please. Data analysis. This is also something that has continued to be a bit of an issue. With the lack of the operational definitions, as I mentioned before, the ability to roll up the data and make assessments on that is somewhat challenged because of that lack of operational definition on what an actual adverse drug event is or a potential adverse drug event. The limited access to data and analysis inhibits the ability to facilitate spread. And then there's there's discussion around the clinical outcome measures that we're following for PSPC and how we've tied the measurement of adverse drug events and potential adverse drug events with the clinical outcomes measures. And the question is that necessary? Knowing that a significant number of adverse drug events happen at transfer, admission, and discharge, is there a necessity for us to tie the measurement of those outcomes with the clinical markers, or can we follow them separately, specifically around transitions of care? And then the serial enrollment issue had swayed the appearance of performance from baseline, and so we need to consider how we calculate a baseline if we're going to follow baseline and improvement overall. Next slide, please. So some suggestions around data analysis. As I've mentioned, this is kind of a recurring theme. Adherence to validated measures is something we would definitely support. We want to have consideration for the separation of clinical outcomes measures and adverse drug events and potential adverse drug events. The tracking should promote continued reporting and process improvement. So for potential adverse drug events where you have a prospective opportunity to make an intervention, the way that things have currently been set up for potential adverse drug event reporting to go towards zero, we feel that that doesn't necessarily promote continued reporting, and we know that errors happen, medication errors are going to continue to happen, and so we would like consideration for potential adverse drug events not to trend towards zero. ADEs, it makes sense that we would want them to be as close to zero as possible over time, but potentials, we have to consider a different proxy measure, I think, on how we evaluate that opportunity for intervention. We would like to see the creation and utilization of unique team baseline data as opposed to a set enrollment period of time for baseline data, as I mentioned before. And a preference toward measures based on electronic record data would be ideal if there are measures that have been specified, such as NQF measures. However, I think it's important to note that there are no specific NQF measures on ADE, and so perhaps with the data that we collect over time, this would allow us to support some measures or promote some measures for NQF on adverse drug events. Next slide. For data reporting again, QIOs have been uncertain which other parties might view access project data. So I think it's important that the QIOs are made aware of any other parties that might be viewing data that is particularly sensitive, since we're dealing with high level of sensitivity data. We found it difficult to document and report additional successes outside of the reported measures, and so we'd like to see some options or the ability to tailor some of the measures that we're going to be collecting specific to each site that is reporting. And then, as I mentioned before, the monthly reporting has been difficult, and it may not be able to identify specific improvements, particularly around clinical outcome measures, such as an A1C result that you might only check every 3 months or 6 months, depending on previous results. And now with the changes to the INR frequency of monitoring, the monthly data submission doesn't always necessarily align as well. Next slide, please. So data reporting suggestions would be to have the QIOs be notified prior to any sharing of any CMS data with anyone outside of the QIO. We would recommend, as I mentioned earlier, tailoring and modification of data collection that is site-specific, not necessarily disease-specific, or aligned with any other existing format. We would also recommend that data submission requirements align with necessary timetables, which is kind of a common theme that I've talked about. Next slide, please. For measure specifications, we've had some issues with understanding the requirements around the measures. Antipsychotics specifically was not really clearly defined, so there was some variability in how you could interpret the language, and there was also not a clear definition or operational definition on a potentially inappropriate medication, which has allowed some variability in the actual data that's been reported. For the clinical outcome measures that we are also collecting around diabetes management, the A1C is not necessarily an outcome or associated measurement for adverse drug events. And so once again, we would draw everyone back to aligning with NQF measures if possible. And then also with anticoagulation, with the changing environment, within medication and the evidence that goes around that. It's really hard when they have specifics on data, monthly data reporting. It's very difficult to adhere to certain specific requirements when the guidelines change so frequently. So we'd like to see some ability to modify quickly. Next slide, please. Measure specification suggestions would be kind of what we've been talking about throughout this presentation. Tailor data collection requirements to the specific setting and not the population of focus or the disease state. So as I mentioned, long-term care, community pharmacy, hospital, and clinics. These are various different sites that operate very differently. They usually may have pharmacists operating within each clinic or each specific setting, and they all need to talk to each other, but the data that they collect in those sites might be very different. So can we tailor the data collection requirements around those sites? The NQS endorsement for appropriate measures, and then allowing flexibility in ADE, potential adverse drug event collection modalities, would be something that would be useful. And then, next slide, please. So the other domain that we wanted to address was communication strategies. Personnel changes in leadership positions can affect how the ADE work is evaluated and how it moves forward. So that has been a slight challenge for us. It's also important to note that there's many different voices reaching out to our partners and our teams. That makes it difficult to tailor messages to individual partners. So our suggestions are, again, to consider endorsement of measures that are aligned with specific quality outcomes like NQS, to provide operational definitions where applicable to hopefully improve the data collection that we see to have it be more meaningful, and then to establish QIO as a communication lead with all sites, and hopefully have a stable leadership to bounce ideas off of and to get direction from, and hopefully those would be drug safety experts. Next slide, please. In summary, I think it's important to note that the QIOs are eager to drive improvement in adverse drug events. There's many successes, as you've heard in the previous topics and the previous presenters. And additionally, there's other positive experiences that we've been privy to learning about in multiple QIOs throughout the country, and those successes are not necessarily reflected in the current data. So a small number of important improvements could result in even greater impact and sustainability over time. And that is all I have. I want to thank the group again for their contribution, and I'll turn that back over to Darren.
All right, great. Thank you so much, Rachel. That's fantastic. You did go a minute over, I think, but that's fine. No, you did a fantastic job, so thank you very, very much. So with that, I believe we may still have Anita Thomas available to us. Anita, are you on the line still? You can unmute with *6*.
Hi, yes, I am. Thank you so much for inviting me to this call. I really appreciate the discussion, the success stories, and the barriers. I was asked to give a brief bio of myself and then just give my comments and thoughts. So again, my name is Anita Thomas. I am now leading the AD work with this body of work, and I'm a clinical pharmacist with a specialized focus in outcomes research and pharmacoeconomics. I was part of the team of pharmacists to help implement the Medicare Part D program, and most recently I was working with the CMS Chief Performance Officer. I'm very excited to be part of the AD work and join this team. This is such an important initiative. As you know, medication errors is a major cause of preventable patient harm. With some of the success stories, I just want to say that I really appreciate hearing the stories. I heard, some of the important key points that focus on high-risk patients, with multiple disease states and multiple medications, and importance in incorporating medication therapy management and coordinated care plans. With some of the barriers, I heard all of the barriers, and I'm definitely going to, take that back. And I appreciate, bringing those issues to the forefront. I will definitely be taking that back. Just to mention that, we will be providing some clarification on some of the issues talked about for the 27th month evaluations. So that'll be coming forth. But I really appreciate being able to hear the conversation and discussion around this work, and again, just want to thank you.
Great, thank you very much, Anita. You have a few more minutes with us?
Yes.
Okay.
Actually, in a few minutes, but
all right.
yeah, I will.
So I guess now is the opportunity for those of you in the audience, if you'd like to submit a question to Anita or to any of the previous speakers. Probably the easiest way to do it is to put it into the chat box and just submit it to the hosts and presenters, or to everybody if you'd like, and I'll reiterate the question, and hopefully Anita or the speakers that you're targeting could answer that question for you. So if you try and just take a moment and submit a question.
Hey, Darren. To get us started, I did have a question for the presenters. I wanted to know how they dealt with patients with low health literacy across their different interventions.
So *6 will unmute your lines. If anyone specifically has worked with a low literacy population or an intervention, we'd love to hear from you.
Darren, this is Jim Kirkland in Texas.
Go for it, Jim.
We did a couple of things. Obviously, I said earlier, we co-opted a lot of things from ARC, and they have some excellent patient literature that's on 6th grade reading level and low literacy level. It's also in Spanish, which is quite important here in Texas. But also, we patient tested some items for type 2 diabetes that were really quite helpful. That the use of avatars, obviously these are translated in Spanish as well, that went over extremely well and are very, very popular here in Texas. One's on how do my medications work, another one's, your blood sugar throughout the day. I mean, the things you typically would offer to patients. And they've been well received and they've worked quite well.
Thank you, Jim. Anyone else speaking to literacy? All right. If you do want to chime in, please go ahead and do so. I do have another question specifically for you, Anita, and I don't know if you have direct information, but maybe you do. We touched on earlier the idea of aligning the work we're doing with other ongoing initiatives. So whether it's the Million Hearts campaign or meaningful use of those things, it's really helpful to get the attention of provider groups and health systems if you're aligning the work of the QIO with what they're doing. Specifically on the side of anticoagulation, we've heard that the meaningful use standards for stage 3, I believe, may possibly include language requiring measures that are anticoagulant specific. And I'm just curious if you know anything about that timeline and the likelihood that any either anticoag or ADE related metrics will find their way into meaningful use. I believe that having those as they reflect back on perhaps on star ratings and things like that for the Medicare Part D plan would be really helpful to us as we try and get attention of not only providers but of EHR companies and folks that are developing software for end users that presently don't address some of these anticoagulant or ADE issues.
Thank you for that question. I can't speak to that directly, but I can say that I am for aligning work, and to whatever extent that we can align work with other national initiatives and programs, we will try our best to do that. But I can't speak to that directly right now. Thank you.
All right. Thank you very much.
Darren, hi.
Yes, thank you.
I spoke recently with the interagency task force through CDC that was looking at anticoagulation. I think you may have spoken with them also, and kind of told them about the types of work that we were working with within the QIO network. And the some result that we did come to at the end of that discussion was that there aren't quality metrics around promoting anticoagulation monitoring. And without a quality metric, it's hard to really drive the attention of others. So I think that is a challenge within anticoagulation. And when I think about that, with all of these, bright people on the phone, I would ask, is anybody aware of any types of quality metrics that have not been previously discussed that would promote medication safety?
One I can speak to directly, Dr. Mims, is that the Pharmacy Quality Alliance, within the last couple of weeks at their own meeting, their membership did endorse a measure that is a claim-based measure of adherence targeting the new oral anticoagulant drugs. So some of the issues we've had, warfarin, you can't really use claims data to assess adherence because the dosing changes so often and the claims don't align very well with adherence. So the monitoring measures are better with that drug. With these new oral agents, there's a lot of concern in the anticoagulation community that without the monitoring, that the adherence rates might fall because you don't have the constant touches of a coag clinic or the INR monitoring, and it's not treating a symptomatic condition. So they're afraid that the trajectory of adherence is going to follow that of other asymptomatic chronic use drugs like antihypertensives, lipid drugs, things like that. So the new measure was passed by the PQA membership, and my understanding is that they will then be bringing that measure forth to our National Quality Forum for possible endorsement. So that would be something that broadens out the metrics for anticoagulation. I don't know of any other measures specific to anticoagulation that might be applicable on the clinic side, but I know there's plenty of interest in the anticoagulation community through the groups that we've been interacting with.
Hi, Dr. Mims and Dr. Triller, Jennifer Thomas.
Oh, go ahead, Jen.
In follow-up to your comments about the Pharmacy Quality Alliance, there's also a medication safety work group, and there is a current measure under definition moving forward on another adverse drug event, so hypoglycemia, where there are actually specific codes, ICD-9 codes identified, and that should be moving into the testing phase, moving to their quality measures expert panel review fairly shortly. So that's another item that may be pertinent, obviously, to our current work.
Thank you, Jen. Does anyone else have any other comments on metrics, specific to adverse drug events that they know that are either in progress or recently adopted by any organizations?
Hey, Darren. This is Rachel.
Hi, Rachel.
Yeah, there's a real lack of metrics, and I think that that's an issue because there's this kind of conflicting interpretation of what an adverse drug event is versus the potential, and then what a med error is, and what an adverse drug reaction is. And these are confusing to people, what I'm finding in practice. So we spent a lot of time educating on what we would recommend as the definitions around those. But to speak to metrics in particular, the only ones that I would bring up outside of what you guys have already mentioned would be the med reconciliation metrics. So NQF endorses MedRec at, I believe it's those three areas, right? Admission, transfer, and discharge. Those are hospital-specific MedRec metrics, but that doesn't capture the MedRec is so not well defined in general, and then it doesn't really capture what happens outside of the hospital setting for med reconciliation, and it doesn't also address the capturing of actual potential adverse drug events and adverse drug events that happen. So there's probably ability to improve those, obviously, but it continues to be an issue.
Great, thank you, Rachel. A couple other measures that pop in mind to me is these on the anticoag side. Time and therapeutic range has been used in many publications, including the randomized controlled trials of these new oral agents for the control groups. So TTR, we do that presently. We receive INR data from our partners and run the analytics for them, doing a Rosendahl time and therapeutic range report. So we do that. And then the recent adoption of the new core measures on the hospital side for stroke and for VTE both now include, I believe, requirements for documentation of patient education upon discharge for people new to warfarin. They do not mention specifically the other new oral agents, which is a bit of an issue, but at least there's an area there that might be something to tap into, and then that would tie into care transitions as well. I'd be interested to hear from anybody on the call from the QIO side working on ADEs that did dovetail their ADE work with care transitions, now that Rachel's brought it up, because I know we've done some of that on our side. The metrics might not be very consistent from place to place, but does anyone have any experiences or success stories they want to share on working with the care transitions and ADE or MedRec?
Darren, Dr. Mims, I did want to add that there is a PQRS measure for medication reconciliation. It's under geriatric care measurement set, and it's for the outpatient environment, and it's looking back for patients who have been discharged from the hospital, whether or not the receiving physician in the primary care setting reviewed the hospital medication. So we do have that out there. It's just not been well promoted, and it is NQF endorsed also. So that would be something to consider for future use, especially within the realm of care transition.
Great, thank you. Anyone else have any experience with share in med-rec and care transitions, aligning the ADE work?
Darren, this is Rachel again. I hate to monopolize the conversation, but
oh, you're great.
We work very closely with our care transitions, and we also work. We found a good dovetailing with our hospital engagement network, working on, again, standardizing definitions so that we're all speaking the same language, so that when we try to communicate back and forth across settings, that we're all making sure that we understand what we're saying about an actual versus a potential versus a med error. Previously, what the hospital engagement network was collecting was a lot of actual med errors and not necessarily adverse drug events, because they didn't consider whether or not there was harm to the patient. And so we've just been trying to really increase our knowledge and share the same operational definitions, promote that across the state, so we can start to collect meaningful data at care transitions.
All right. Now, Rachel, did you work specifically in your care transitions with recipient facilities, like long-term care facilities, rehab? Because I know that's some of the work that we've done in our own care transition networks here in New York. And others earlier in this presentation mentioned long-term care and some of the barriers and things. Do you see care transitions and some of the ADE work dovetailing with long-term care facilities specifically for opportunities?
Oh, absolutely. Yes. It all ties together, really, between the hospital and the long-term care, depending on where they're going at discharge. Working with the long-term care facilities to establish understanding of what that means, how to collect adverse drug events, potential adverse drug events. So, yeah, we've been looking at all of that as well.
I had an opportunity last week to speak to some folks from our New York State chapter of the Society of Consultant Pharmacists, and it became very obvious that the model for pharmacy services, consultant services, and long-term care isn't sufficient to proactively drive quality improvement like certain high-risk drugs. So, the ADEs with warfarin, it's always after the fact, and we're seeing that their time therapeutic range isn't very, very good. I mean, the facilities, but yet the consultant pharmacist isn't really empowered with lab data and things proactively to help with dosing and things like that. So I think long-term care would be a very interesting area.
Yeah, so, the reimbursement model for the pharmacist too within long-term care is I mean, it's a struggle. But so we're really relying on hospitals to help promote communication with that facility and talking to the nursing staff and the interdisciplinary teams at the long-term care facility, because the pharmacist isn't there all the time to do that sort of evaluation. At this point.
Great. Now, Dr. Mims just quoted a great question via the chat room, so I really would like to get some input from those of you in the audience of what do you think the focus of the 11th scope of work should be regarding medication safety. So what is your ideal scenario, your ideal scope of work for ADE work going forward? If you got to write the scope of work, what does it look like? I may have to pick on individuals I know are on the line. All right. So I'm thinking, would one of our speakers from the success stories be willing to chime in? Jen or Jim?
Darren, this is Jim. Can you hear me?
Yes, I can.
Okay, great. I personally think aligning, and we just talked about this a moment ago, you and Rachel and Dr. Mims, I think, as well chimed in, that aligning drug safety with what we're already doing, I think specifically with care transitions, is extremely important. Not only is it, promoting better quality of life for those patients as they get out of the hospital or preventing them from getting in the hospital, but it's, it's following their care through med recon once they get out of the hospital. So, I really believe that aligning drug safety with care transitions would be extremely important, and maybe that's where we're going anyway, but that's just my opinion.
All right, thank you.
Hi.
Gary, Jen, or Gina, do you have any high goals or visions of what you'd like to see the ideal scope of work look like that you're willing to share?
Can you hear me?
I can.
Oh, good. Yeah, Jen Thomas again. I would follow on with what Jim indicated, and I think the alignment with care transitions would be excellent, but then I'd take it a step further in that there should be some requirement to include the community pharmacist and moving towards some accountability and responsibilities to connect those patients that are discharged with their pharmacy and with including them as a provider.
I like that. Now, Jen, based on your experience, how realistic might a measure or a component of the work be to promote pharmacy access to current lab data through these exchanges and things? If you use that as a metric in our state right now, it would be 0%. 0% of pharmacies in the community access concurrent data on problem list diagnoses and labs. Do you have a sense in your state with your exchange what that penetration is and would be realistic perhaps to make that a target? Because that would engage the pharmacists in the community, all these rural and urban settings, inpatient care more actively.
Currently, we're in the infancy here, so I'm not sure where that target might be, but as we connect, I think the expectation should be there. So as a corollary here in the state, we have a mandatory responsibility by law to report to our Immunet, our immunization registry, and that moves forward this year for all vaccinations provided by pharmacy. So I think it could be a similar type of a corollary, but then the exchanges would be required to allow access to the pharmacists, that they would be registered accounts and have access. So I think it's some work in both those areas, and then obviously the resources to support connectivity.
All right. Thank you. Does anyone else have any other comments along those lines? I've got a couple other questions popping in, but I'll pause for 30 seconds if somebody wants to chime in with something else.
Darren, this is Ken Mishler.
Oh, hello, Ken.
Great presentation. I just thought I'd chime in. Kansas is obviously in its infancy stage for health information exchange. It's growing very rapidly, but they are actively recruiting pharmacies to become a part of the exchange for just the reasons we're talking about. And in fact, one of our PSPC teams was actually the very first pharmacy to sign up for that. Now, the data is not starting to flow. There's not a robust amount of data flowing just yet, but it is a selling point for us for pharmacies to join their information exchange for not only receiving data but also providing data.
Now, Ken, were those chains or independent pharmacies?
Independent pharmacies right now the chains are on it. I think the chains are a lot more encouraged to join just so that they're included and being first. But they are really marketing the exchanges here in Kansas. There's 2 of them. They're marketing to independent pharmacies.
All right, thank you.
Because they need their data. They want their immunization data. They want them tapped into the immunization registry. They see medication reconciliation as a huge opportunity for engaging pharmacy, and they really want their data. So getting them involved has really been an important part of the marketing of health information exchange in Kansas, which is, again, only a year old.
All right, thank you, Ken. Let's see. Was somebody else trying to talk in also? I think I heard a female voice when Ken first started. Somebody wanted to speak?
Hey, this is Lori Thomas in Indiana, and I was just going to say that I agreed with Jen Thomas when she indicated, the ideal state of definitely coordinating with care integration, but I also think it's important that we look at medication safety in long-term care, and as that is part of the care integration work as well, but I just think it's important to reiterate that.
Yeah, and I agree too with that, because we had that discussion again with the consultant pharmacist just last week, and I don't think the state of the art is for the dispensing pharmacy or the consultant pharmacies to have remote continual access to lab data and things like that. It's very much a retrospective review, things like that, and there's so much room for improvement. So I think pharmacists in these key settings, community pharmacy, long-term care, that to be part of that proactive care team, I think makes a lot of sense.
Yes, and we're seeing a lot of success with that with our consultants that we're working with.
Wonderful, thank you. And I think there was another voice trying to enter in as well.
Yeah, this is Gina from North Carolina. As far as what I think would be a good piece of the 11th scope of work would maybe be to include the Medicaid population, because when we were trying to recruit a number of teams, they pretty much were disqualified because they had a huge population of uninsured and Medicaid. And while those locations, mostly FQHCs and community health centers, really wanted to participate and have the support of the QIO, we couldn't partner with them because they did not have any Medicare. And as we all know, a large population of Medicaid are the high risk. So I feel like it was unfortunate that we could not work with that group, and they really, really could have used our help. So maybe the 11th scope of work will, allow us to work more with pure Medicaid and uninsured. I don't know. That's
great. Thank you.
I would echo those comments also. That's a great suggestion, the way it is in Kansas.
Oh, wonderful. All right. Now we're down to about 5 minutes left. I'd like to actually put the ball back in Dr. Mims' court to get any of the final questions or comments. I know we are going to be providing the summary and the recording back to CMS, and we can disseminate that tool that we aggregated the barriers with. But are there any specific other questions you have, Dr. Mims, or are there any other members of your physician leadership network, because they're the hosts of this call, to see what other questions or input your group might have?
Well, I would also put out the question, since most patients are not in the hospital, what outpatient initiatives should be a focus of future work?
This is Darren again, and I'm maybe a bit biased, but I think the anticoagulation issue, the emergence of the new agent adherence rates, and the level of poor warfarin monitoring, I think this kind of broader approach to anticoagulation stewardship, regardless of setting, I think makes good sense. And if there's measures and metrics that are coming forward, I think that'd be a great, more global approach to patient care. So inpatient and outpatient connectivity and quality with HC.
Okay, you are biased.
I am.
But there's also the Beers list, the revised Beers list, that deals with a whole lot of other medications, and some of those have actually gone forward to become part of HEDIS measures of high-risk medications in the elderly. So what should be some other areas that we should consider besides anticoagulation? Some thoughts?
Hey, Adrian?
Yes?
This is Jim Mitchell from Michigan. I know this is still anticoagulation, but one of the things that we're concerned about in emergency rooms is older people that are on these new anticoagulants are coming into the ER, and I'm wondering if we shouldn't be monitoring them to see how many of them are coming in with adverse drug reactions.
Sounds good.
Well, not only adverse drug reactions, but also complications of the anticoagulant, because we have no way to reverse them. That we're really worried about that.
Okay. And I agree with you. That it is very important. When you look at the highest rates of hospitalization or ER visits, it is the anticoagulations and the medicines for diabetes. So we definitely think that those would be important going forward. I guess that the take that I have on this is that, most Medicare patients don't get hospitalized in a year, but yet they are having adverse drug events from all the other medicines that they're using. So I would like to see that we look beyond just two medication classes, but begin to look at medication literacy or medication education in a more broader state to try to prevent those hospitalizations from occurring. So I think that, as people were saying, the role of the community pharmacist can be a lot broader in that regard.
Dr. Mims?
Yep.
This is Rachel. I know I put this in the chat function, but PQA, I believe, is tracking a measure on CMR rate, so Comprehensive Medication Review, which is the review that happens at the community pharmacy level if the community pharmacy is providing medication therapy management services. So that's an if. And then also the patient has to qualify for coverage of the service. There's two things that have to be considered there. But CMR, tracking the level or the amount of patients who receive CMR in a community pharmacy setting and tracking that back to admission, readmission rates might be something to consider because it's comprehensive. And it's something I think all patients would benefit from, not just those who are on more than 5 meds or something like that, but maybe that's something that you guys could consider.
I like that. And with the advent of e-prescribing, is there some other things we should be considering?
Hey, Adrienne, this is Claire. Another thought in response to kind of what should we do, what should we think about for the next scope of work, I think, and this is touching on what a lot of people said, we work with our patients in terms of their electronic health records and helping them use those electronic health records to improve the management of patients. And currently it's around cardiac health and cancer screenings and immunizations, but I think there's a huge need in terms of understanding the patients in terms of the medications that they're on and the interaction. So I think we can be supportive of physicians in their practices around medications and potential adverse events.
I like that. We have 1 minute before closure. This has been an excellent conversation. I thank all of the presenters, and specifically a big thank you to the facilitator today. Darren, you did an outstanding job. Thank you for all participating. Those of you who are on the webinar, you can see that there's an evaluation that you can click on and do at this time. Those who complete the evaluation will receive a certificate of completion. Everyone who logged into the webinar, we have your email addresses, so we will be sending you a set of the slide for your interest. Those of you who are only on the telephone, if you are interested in receiving a copy of the slides, you can send an email to me. We'll make sure that we get that out to you. So thank you very much for all who participated today.
Thank you very much. Have a great afternoon, everyone.
Thank you.
Thank you.